Hi, my name's Reshma. I'll be giving the ONG lecture today. So the topics I'm going to be, this is the second ONG lecture that I'm giving, and the topics that I'll be covering are maternal medicine, medical disorders of pregnancy, management of the intrapartum stage, obstetric emergencies, multiple pregnancies, and the postnatal period. Okay, so the first thing that I'm going to start off with is terminology. So in obstetrics, especially when you're taking obstetric history, you'll often find the words gravida and para being used. So gravida is the number, how many times a woman has been pregnant, including her current pregnancy, irrespective of the outcome of pregnancy. And para is the outcome of pregnancy. So you often find like G and P, and then you have like a number plus another number. So for gravida and para, so it's like gravida 5, para 4 plus 1 or whatever. And so the para is the outcome of pregnancy, the first number being the number of pregnancies greater or equal to 24 weeks duration, whether the pregnancy resulted in a live birth or a stillborn. And the second number, so B, is the number of pregnancies under 24 weeks. So any pregnancies that ended in a spontaneous or induced miscarriage, any terminations of pregnancies, or any ectopics. So that's what's included in the second number. So by these definitions, para, so the second number, so para can never be greater than gravida by this definition. And when a woman is pregnant, her gravida will, the number that is for her gravida will always be one more than the para number. I find that this is much easier to understand if you have a few examples. So if we work through these examples, the first one being what would the gravida and para be if a woman is pregnant with her third child and she's had no previous miscarriages? So if she's had no previous miscarriages, that must mean that her 2 previous pregnancies ended in giving birth to a child that was either equal to or greater than 24 weeks gestation. So her para is going to be 2 plus 0. She's currently pregnant, so she's had 3 pregnancies, so her gravida and para would be G3 P2 plus 0. Okay, the next one, her first, actually it might be an idea if you want to just pause the video here and then try and work through it, and then I'll bring up the answers. I feel like the second one is kind of easy, so I won't work through it. Which one should we try? Maybe I'll just go through the 5th one, just to save time, and then I'll reveal the answers and you can have a look. So you can pause the video here if you want to try and work them out yourself. Okay, so the 5th one, if a woman is 22 weeks pregnant currently, she has twin sons aged 6, she has a daughter aged 2, and she had 3 first trimester miscarriages. Okay, so the 3 first trimester miscarriages is the easier part to work out. So you know that that B is going to equal 3. She had twin sons aged 6 and a daughter aged 2. However, even though she gave birth to twin sons, so she had 2 sons and 1 daughter, it was only 2 pregnancies. So A equals 2, and she's currently pregnant, so gravida would equal 6. Okay. Another 2 terms that are used a lot in obstetrics are engagement and attitude. So when we say engagement, what we mean is it's when the widest presenting transverse diameter of the fetal head has passed through the brim of the pelvis, and if engagement occurs, it means that it's likely that the fetus will be able to be delivered vaginally. So that it means that the maternal pelvis is basically of an adequate size to deliver the baby vaginally. In a woman that's pregnant for the first time, this usually occurs. So the head usually engages any time from about 36 weeks of pregnancy. But if a woman's given birth before in the past, engagement might not happen until very soon, very close to the onset of labour. So it can be up to 30th week of pregnancy. And the way that you tell if the head is engaged is if only 2/5 of the head is palpable, of the fetus's head is palpable abdominally. That tells you that the head is engaged. And attitude refers to the relationship of the fetal body parts to one another. So a normal attitude is if the body is in full flexion. And if the fetus is in deflection or extension, it can result in feto-pelvic disproportion and dystocia, which is an abnormal labour. Okay, so the components of an obstetric history. So the key parts that differentiate an obstetric history from a normal medical history would be you need to take a reproductive history, so you need to ask about gravida para. So you need to know about the number of previous pregnancies. So it's easy to do this in to do it in chronological order. You need to ask if there are any complications with any of them, the outcome of each pregnancy, the birth weight, the sex of each fetus, the sex of each birth of each baby. You need to ask about miscarriages, so how many miscarriages they've had, when they occurred, how are they managed, the attitude to pregnancy loss is also important. You need to ask about any terminations of pregnancy as well. You should, in the reproductive history, you would also ask about contraception. So if they have used any contraception in the past or when they stopped using it. In an obstetric history as well, because the patient is obviously pregnant, so it's important to find out the gestational age, so how far along they are. So you could work this out from the last menstrual period, and then from that you could work out their estimated due date. It's important to find out what the reason for the visit is. Is this just a routine appointment, or is there a problem? So have they come in with any bleeding or pain? So that's important to note. It's important to get a gynecological history, so if they've had any gynae problems in the past, and then any past medical history, any previous surgeries, so C-sections in particular are important to find out about. Social and family history are important. So social, you need to ask about drinking, alcohol, recreational drug use. With family history, things that are important to find out about are any family history of diabetes, any family history of preeclampsia, any blood clotting disorders that run in the family. And in the booking visit, so that's the first appointment after patient finds out that she's pregnant. It's in that appointment that they're risk assessed, and so it's then decided based on the individual's risk whether they'll be managed with midwife care throughout their pregnancy, or whether they'll need to see an obstetrician during their pregnancy. Okay, so an obstetric examination. When a lady first presents for the first time, the three key things that need to be checked are blood pressure, because you need a baseline blood pressure that at the beginning of pregnancy. when a woman is pregnant, what usually happens is typically the blood pressure falls, and then towards the end of the pregnancy, it comes back up to what it was at the beginning of the pregnancy, if that makes sense. And the reason why blood pressure is important is for conditions such as preeclampsia, so you need to know what their baseline is. Urine dipstick is important. On the urine dipstick, you're going to look for sugar, for glucose, because the risk of gestational diabetes that can occur in some women. And you're also going to look for proteins, again for preeclampsia. And then the other thing that you check is weight, just so that you have like a baseline weight. And then with the obstetric examination, the uterus should be palpable. It is palpable usually from abdominally, so without a vaginal examination. Obviously, when you're doing a vaginal examination, you can bimanually palpate the uterus, but you can palpate the uterus just abdominally from about 12 to 24 weeks. At 20 weeks, the fundus usually reaches the umbilicus, and at 36 weeks, it reaches the xiphisternum. So symphysiofundal height, or SFH, the way that you measure this is you find the fundus with your with the border of your hand, and so it's good to start from the xiphisternum and then move downwards with your hand until you feel the edge of the fundus. And what you do is you measure from that point down to the pubic symphysis. And after 20 weeks, the SFH should match the gestational age in weeks by like plus or minus 2. And it's a good way of like monitoring fetal health. And so if you find that actually it's not measuring up, then you might need to do like an ultrasound scan to see what's going on, because it can, if it's less than that, it might be indicative of intrauterine growth restriction. Or sometimes you get reduced SFH if the baby's in if the fetus is in an abnormal position. So the other things that you can do is you can palpate for fetal lie. So lie is the direction of the fetal spine with respect to the long axis of the uterus. So most, like in the majority of pregnancies, the baby will be longitudinal. So the baby's spine is like is in line with the mother's spine, if that makes sense. It's not perpendicular. Transverse lie is when the baby's spine is perpendicular to the mother's spine, and it's associated, like we said, with reduced SFH. Fetal presentation is basically the part of the part that lies lowest in the uterus. If the lie is longitudinal, it will either be a cephalic or breech presenting part. And the way that you check for fetal presentation is like with one hand you kind of feel the lower, like in the suprapubic region. You can like feel the if they're cephalic, you can feel the fetal head. That's fine. And if they're transverse or oblique, if the lie is transverse or oblique, the presentation might be a shoulder or an arm. Okay. So in summary, main components of an obstetric examination: fundal height, so SFH measuring, checking the presenting part, 2 lateral grips, so that's when you kind of like feel down like the sides of the abdomen, and you should be able to like feel like if the back is on one side, it's like a smooth and convex surface. And then also you would listen for fetal heart with like a sonic aid, fetal heart sounds, and that's usually you listen over the fetus's anterior shoulder, and it's like a fast heart rate. It's like 110 to 160 is normal. Okay, so transverse lie. So we mentioned that this is when the fetal longitudinal axis is perpendicular to the long axis of the uterus. The most common presentation is scapulo-anterior, so that's when the fetus is like facing the mother's back, or you can have the other way, which is scapulo-posterior, where the fetus is facing towards the mother's front. Early in gestation, it's really common to have this kind of presentation, but most, like towards the end of pregnancy, or by around 32 weeks, most babies kind of have moved into a longitudinal lie. And the risk factors for having a transverse lie, like towards past 32 weeks, the risk factors for this are having fibroids or other pelvic tumours, because that can make it difficult for the baby to position, if that makes sense. Being pregnant with twins or triplets. Prematurity, which makes sense because if a baby's born prematurely, it might be before it has time to move into a longitudinal lie. Polyhydramnios, I spelled that wrong, but polyhydramnios, the way that I remember this, I don't know if this is true or not, but the way I think of it is if there's too much amniotic fluid, it's easier for the baby to kind of move around and to end up in an abnormal position. And also fetal abnormalities as well are a risk factor for transverse lie. The way it's diagnosed is it can be diagnosed by abdominal examination. So when you go to palpate the presenting part, you're not able to feel the head of the fetus. The fetus can be felt to be lying like directly across the uterus, and you might also find that the SFH is reduced. And then an ultrasound scan will allow direct visualization of the fetal lie. So complications of a transverse lie, it can result in preterm rupture of membranes. It can result in cord prolapse, which is where the cord presents before the presenting part of the fetus. And if allowed to progress to vaginal delivery, which very rare in the UK, usually something is done about it before it gets to that. So if allowed to progress to vaginal delivery, compound presentation may occur, which is where like another body part, so say like an arm, comes through at the same time as the presenting part, so it's the same time as the head. That's what compound presentation is. Okay, so how it's managed. So nothing's really done until after 36 weeks because there's still a chance that the fetus might move to a longitudinal lie. But at around 36 weeks, an appointment is made with the obstetric medical antenatal team to discuss what to do. So there are different options available. One of them is to perform external cephalic version of the fetus, and this is basically where you kind of manually try to manipulate, like from like pressing the abdomen, you try and manually manipulate the fetus to turn. And you can YouTube this and see how it's done, but it's just manipulation with the hands on the abdomen. So this can be performed late in pregnancy and even early on, even early in labour, as long as the membranes have not ruptured yet. And it's offered to all women who want a vaginal delivery, who don't want to go through with a C-section. There are some contraindications to it. So if the mother has had any bleeding during pregnancy in the last 7 days, you can't go ahead with it. If there's twin pregnancy or triplet pregnancy, you're not able to go along with it. If there's any abnormalities with the uterus, and with this method, it's like got a success rate of 50%. The other option, if you don't do external cephalic version, or if external cephalic version is not successful, you would move to do an elective C-section. And so the decision to perform a C-section over ECV is based on perceived risks to the mother, fetus, preference of the mother, any comorbidities, and the ability of the mother to access obstetric care rapidly. Okay, so breech presentation. So frank breech is the most common. It's where the fetus's hips are flexed, the knees are fully extended. So you can see, oh no, that's showing ECV, never mind. So it's where the fetus will present with like the buttocks coming first, because if you can imagine, the knees are flexed, the hips are flexed and their knees are fully extended. Footling breech is more rare, and it's also got a higher perinatal morbidity, and that's where one or both feet come first with the bottom at a higher position. So the risk factors for breech presentations are any uterine malformations or fibroids, placenta previa, which is where you have like a low-lying placenta, polyhydramnios or oligohydramnios, fetal abnormality, prematurity due to an increased incidence earlier in gestation. So basically, earlier in gestation, breech presentations are more common, but most babies kind of turn towards the end of pregnancy. But if you're premature, then you might not have that time to get into a cephalic position. And cord prolapse, same as with transverse presentation, is more common. So management, again, 36 weeks is the cut-off date. So if you're under 36 weeks, many fetuses, they'll turn spontaneously. However, if there's still an abnormal position at 36 weeks, two options, again, the same as with transverse presentation, transverse lie, external cephalic version. So it's offered from 36 weeks in first-time mothers and in at 37 weeks in multi-parous women. And then the other option is planned C-section. So the absolute contraindications to ECV are if a C-section is required, antepartum hemorrhage within the last 7 days, if you have an abnormal CTG, and CTG kind of, abnormal CTG indicates fetal distress often, if there's any major uterine abnormalities, if the membranes are already ruptured, or if it's a multiple pregnancy. Okay, so antenatal care. The aims of antenatal care are to detect disease or any risk factors for developing disease in the mother, to solve any discomforts of pregnancy, to monitor and promote fetal well-being, to prepare the mother for birth, so it's a lot of education that goes into antenatal care, and to detect any early complications. So health promotion and advice, some of the things that are included are what medications that pregnant women should avoid, advice on like keeping a well-balanced diet, folic acid supplementation, advice on like avoiding sex during if you have placental previa, avoiding alcohol and smoking, avoiding listeriosis infection by not having unpasteurized milk or blue cheese, and exercise. So these are all kind of things that are advised upon in antenatal care. Okay, so this is a screening timeline for pregnancy. I'm going to go into it in a little bit more detail, but I'm just having a look here. Important things to note: preconception is when you should start folic acid, and then you continue it until about 12 weeks. So even before, so when you're planning to get pregnant, you should be on folic acid. Then at around 8 weeks, you kind of have these blood tests for like sickle cell and thalassemia. You have like a test for like your rhesus antibodies, and then around the dating scan, around this time you'll also have the first test for Down syndrome. You'll then have a detailed anomaly scan at around 20 weeks. Yeah, those are the key ones, but we'll go into it in a bit more detail now. Okay, so the first appointment that you'll have is your booking visit, and that will be at 8 to 12 weeks at some point. It's carried out by the midwife, and at this point they would risk stratify you, and they'd risk assess you and decide whether you're going to have hospital care or continue with midwife care during your pregnancy. So at this first visit, there's some blood tests that are carried out, so a full blood count to check for anemia, a hemoglobinopathy screen, so to look for sickle cell or thalassemia. Your rhesus status is checked as well. You're checked for syphilis, HIV, rubella, Hep B, You have a random blood sugar as well. At this appointment, you're given kind of general info on diet, alcohol, smoking, folic acid, vitamin D, and given advice on like when antenatal classes are and things. And again, like we said, booking visit, 3 things that need to be checked: blood pressure, urine dip, and weight, so BMI. At every subsequent visit that you have, you need to have a blood pressure check. Women need to be offered a blood pressure check. It's important for preeclampsia, and a urine test, which is important for preeclampsia as well, and UTIs and diabetes. So the next appointment that you'd have is the dating scan, and this kind of confirms the date. So the way that it does that is by measuring the crown to rump length, and it also excludes any multiple pregnancies at this point, or confirms multiple pregnancies at this point. Around this time, you'd also have Down syndrome screening, which is the test that's offered is the combined test, so a nuchal translucency measurement, which is done using an ultrasound scan, and it measures the thickness around the neck folds. And remember, this is just a screening test. It doesn't give a definitive diagnosis of Down syndrome. The other thing that's included in this combined test is a serum beta HCG level and also pregnancy-associated plasma protein A. Then at 16 weeks, information on the anomaly scan is given. So information is given on what the anomaly scan is, what is looked for in the anomaly scan as well. If a patient's hemoglobin is less than 11 grams per deciliter, they're considered for iron supplements. And again, routine care, blood pressure, urine dip is done. So the anomaly scan, the things that it looks for are spina bifida, major cardiac defects such as VSD, any hand abnormalities, femur length. If it's less than the third centile, then you might do like a full skeletal survey. You look for hydrocephalus. You look for the lemon and banana sign, which are indicative of a neural tube defect. And you can also see if you have a low-lying placenta. However, for most women, if you find a low-lying placenta on the anomaly scan, placenta does seem to move up, but you need, if it's found on the anomaly scan at 20 weeks, you need a repeat scan after 34 weeks to confirm that the placenta has moved up. Okay, you would then, only if you're a first-time mum, you'd have another routine appointment at 25 weeks. This will involve blood pressure, urine dipstick, and an SFH measurement at 28 weeks. Again, same things: blood pressure, urine dipstick, SFH. You could have a second screen for anemia and atypical red cell alloantibodies. And if your hemoglobin is less than 10.5, you're considered for iron. If you're rhesus negative, which you would have found out at your first blood test, you would be given your first dose of anti-D prophylaxis. At 31 weeks, first-time mothers have another routine appointment: blood pressure, urine dipstick, SFH. 34 weeks, you would, if you had a low-lying placenta, you'd be rescanned at 34 weeks. You have the second dose of anti-D prophylaxis for rhesus negative women, and at this point you're also given some information on labour and your birth plan. At 38 weeks, another routine appointment, BP, urine dipstick. 40 weeks, only if you're primary. Blood pressure, urine dipstick, SFH, and then you discuss options for prolonged pregnancy at 41 weeks, because you're now possibly past your due date. You will discuss the possibility of induction. So for patients who are in their first, for whom it's their like first pregnancy, if it's uncomplicated, they'll have around 10 antenatal appointments. For subsequent pregnancies, if they're uncomplicated, they'll have around 7 antenatal appointments. But it is dependent on, you know, if a woman's pregnancy is complicated or not. So if they have another health condition, then they might require more antenatal appointments. I also want to spend a little bit of time talking about Down syndrome antenatal testing. So the first test that is offered is the combined test, which is very early on in the pregnancy. However, some women present later in their pregnancy, and if they do book later in their pregnancy, they are offered either the triple or quadruple test. And this is done around 15 to 20 weeks. So the triple test is includes AFP, unconjugated estriol, and HCG, beta HCG. Quadruple test is AFP, unconjugated estriol, HCG, and inhibin A. And I've just put down here what the different results are for each of these tests that are like positive findings, which kind of indicate an increased risk of Down syndrome. Remember, it's not diagnostic, so it's a screening test. So if you have a decreased AFP, increased beta HCG, a decreased estriol, an increased inhibin A, those would warrant that actually you're an increased, that the scan shows that you're increased risk, or that there's a possibility that the fetus has Down syndrome. And so in order to get a diagnostic, and it would mean that you might want to consider a diagnostic test at this point. Okay, so what are the prenatal diagnostic tests? There's two. There's chorionic villi sampling, so CVS, or amniocentesis. So CVS involves taking a small amount of placenta under ultrasound guidance. It can be carried out after 10 weeks of pregnancy. It's done transcervically. It's done transabdominally if you're doing it after 13 weeks, though. The risk of miscarriage is about 2%. And if at that point, if after the prenatal diagnostic test, you decide that you want to terminate the pregnancy, it would involve an operation to empty the uterus. With amniocentesis, it involves taking a small amount of amniotic fluid under ultrasound guidance. It's normally carried out 15 weeks after 15 weeks of pregnancy. The risk of miscarriage is slightly lower, just 1%, but ending the pregnancy may involve going into labour, because it's the test is further along in the pregnancy. Okay, so preconception counselling. Some important key points include weight. So having a high BMI is associated with subfertility, actually extremes of BMI. So having a low BMI or having a high BMI, both are associated with reduced fertility. So advising on weight loss, or how to increase weight. So just nutritional advice is really important for people who are struggling to get pregnant. Folic acid, so it reduces the risk of neurotubal defects. So for the general population, for most women, it's recommended to have 400 micrograms in a day if you're low risk. But if you're high risk, so high risk groups include, so high risk of neurotube defects, sorry. So high risk groups are epileptics, so women who are on anti-epileptic medications, women who have diabetes, women who have high BMI. They're recommended to have 5 milligrams a day, so a higher dose. It's important to let women know that high levels of vitamin A have been associated with, have been found to be teratogenic. So it's important to avoid any supplements that are very high in vitamin A. and avoid foods such as like liver, which is very high in vitamin A. The importance of vitamin D supplementation should be advised, especially in those with low vitamin D, exercise, stopping alcohol, caffeine, and smoking, and recreational substances. So for women with heart disease, they should be referred to a cardiologist for review. They should be given thromboprophylaxis because during pregnancy you're at increased risk of VTE, and statins should be stopped, which is important. For epileptics, they should be referred to a specialist, usually because anti-epileptic medications are associated with a lot of them are associated with neural tube defects or cleft palate, or cardiac problems in the fetus as well. However, that risk to the fetus needs to be balanced against the risk to the mother from not having adequate anti-epileptic medication, so being subtherapeutic. So what's usually you need to continue with some form of anti-epileptic because there's a serious risk by not being on your medication, because you can have your seizure threshold is reduced, which puts the mother and the fetus at risk. So usually what's done is monotherapy is continued at like the lowest dose to continue to be therapeutic, but also to reduce any risk to the fetus. And also women with thyroid disease as well. There's usually, they have like specialist clinics for women with thyroid disease to be seen. So pregnant women to be seen with thyroid disease to make sure that they're receiving optimal treatment. Okay, so pregnancy and diabetes. So diabetes complicates up to 1 in 20 pregnancies. So the vast majority of these are women who have gestational diabetes. So a vast majority of these cases are gestational diabetes. However, 7.5% have type 1 diabetes, like pre-existing type 1 diabetes, and 5% have pre-existing type 2 diabetes. So management of pre-existing diabetes. The first important thing is weight loss for women with a BMI of over 27, because that will just improve their fertility if they're planning to get pregnant, and also it reduces so it increases their likelihood of becoming pregnant. If they're on any oral hypoglycemic agents, they all need to be stopped apart from metformin. And if they're not well controlled, if their blood sugar is not well controlled and just metformin, then they're started on insulin rather than any other oral hypoglycemics. Women with pre-existing diabetes need to be on folic acid 5 milligrams per day from when they're planning to get pregnant up until 12 weeks gestation. They also need to be taking aspirin prophylactically, so 75 milligrams a day from 12 weeks until they give birth, and that's to reduce the risk of preeclampsia. They require a detailed anomaly scan at 20 weeks to check for any like cardiac malformations. They need tight glycemic control to reduce complication rates, and they also need to their eyesight also needs to be checked because retinopathy has been found to worsen during pregnancy. So this is the management of a woman with pre-existing diabetes. So now what we'll do is we'll talk about gestational diabetes. So there are the risk factors for developing GDM are having a raised BMI, so BMI over 30, having a previous baby that was over 4.5 kilograms, which I believe is 10 pounds, having gestational diabetes in a previous pregnancy, having a family history of diabetes, so in a first degree relative, or having a family origin with high prevalence of diabetes, so South Asians, Black Caribbeans, and Middle Easterns. So if a woman has any one of these risk factors, they should be screened for gestational diabetes. And the way that the screening program works is you do an oral glucose tolerance test. So for high-risk women, high risk is anyone is a woman who's previously had gestational diabetes. So for women who've previously had gestational diabetes, they have an oral glucose tolerance test after their booking appointment. And then they'll have a repeat of that test at 24 to 28 weeks if the first test is normal. If you don't want to do the oral glucose tolerance test, early self-monitoring of blood glucose can be done as an alternative. So for women with any of the other risk factors, so raised BMI, a family history of diabetes, family origin with high prevalence of diabetes, for those women, they should be offered a glucose tolerance test at 24 to 28 weeks. Okay, so the diagnostic thresholds for gestational diabetes are a fasting blood glucose of 5.6 or higher, or 2-hour glucose of 7.8 millimoles or higher. So that's like after you've had, after you've taken the glucose from the glucose tolerance test, 2 hours later, what your blood glucose measurement is. Other things such as like glycosuria, so high sugars in the urine, or like having polyhydramnios or macrosomia may indicate GDM as well. Okay, so the way GDM is managed. So women who are newly diagnosed, so they've just done the OGTT and it's found that they have GDM, so they've been diagnosed because their fasting glucose was 6. They're seen in a joint diabetes and antenatal clinic within a week of being diagnosed. At this point, they're given education on how to monitor their blood glucose at home. The targets for self-monitoring, and this is the same actually for women with pre-existing diabetes, the targets for self-monitoring are having a fasting blood glucose of 5.3, 1 hour after meals checking your blood glucose and it should be around 7.8, and 2 hours after meals it should be 6.4. They should be given advice about diet first and foremost, so eating foods with low glycemic index and exercising regularly. So if on presentation their fasting blood glucose is less than 7, so let's say that their fasting blood glucose is 6, first thing that should be done is trial of diet and exercise. And you set a target, okay, target fasting blood glucose should be 5.3. After 1 to 2 weeks of trialing diet and exercise, if the glucose targets are not met, then metformin is started. Okay, so as you can see, there's only a very short time period where you're able to trial things before you move on to the next step, because I mean, you're trying to correct things as quickly as possible in the pregnancy to prevent complications. So if diet and exercise isn't working after 1 to 2 weeks, you commence metformin. If the targets aren't met, again, after 1 to 2 weeks, then you would begin insulin. So you'd start insulin and continue still with diet, exercise and metformin. If at the time of diagnosis, so if the fasting blood glucose were 7.5, so above 7 or more, insulin should be started from the get-go, so rather than trialing diet and exercise and metformin. If the plasma glucose level is between 6 and 6.9, and there's also evidence of complications such as macrosomia or that should say polyhydramnios, insulin should be offered straight away. Glibenclamide should only be offered for women who cannot tolerate metformin or those who fail to meet glucose targets with metformin but decline insulin treatment. So glibenclamide is a sulfonylurea, and usually oral hypoglycemic agents shouldn't be offered in pregnancy. It should just be metformin or insulin. But if a woman can't tolerate metformin, maybe because of the GI side effects, or if they're not able to meet their glucose targets on metformin, but they're saying that they don't want insulin, at that point you could offer glibenclamide. Okay, and so in terms of postnatal care for women with GDM, fasting glucose at 6 weeks postnatally is required to exclude type 2 diabetes. And it's important to note that women who have had GDM are at high risk of developing type 2 diabetes later in life, and also at high risk of having GDM in a future pregnancy. Okay, so the complications of gestational diabetes. So we've covered a few of these. So fetal macrosomia, polyhydramnios, birth trauma for the mother and baby. So if you have a bigger baby during delivery, there's increased risk of trauma, there's increased risk of like shoulder dystocia, miscarriage, there's a great risk of miscarriage, and congenital malformation during the pregnancy. So 3 times increased risk of like heart and neural tube defects, which is why it's important to have, for the neural tube defects, it's important to have the folic acid, 5 milligrams per day. 5 times increased risk of stillbirth, 3 times increased risk of neonatal death, and an increased risk of diabetes and obesity in the baby later on in life. Maternal complications include recurrent UTIs and candida, preeclampsia and hypertension and pregnancy-induced hypertension, preterm labour and acceleration of diabetic retinopathy. Neonatal complications include hypoglycemia in the baby, respiratory distress syndrome, transient tachypnea of the newborn. Okay, so pregnancy and hypertension. There's 3 conditions that we need to cover. So the first one is pre-existing hypertension. This is where a woman is pregnant who, before pregnancy, she had a history of high blood pressure. And so it's a blood pressure of above 140 over 90 before 20 weeks gestation. Okay. There's no proteinuria, so no protein in the urine, and no edema. This occurs in 3 to 5% of pregnancies, and it's more common in older women. The next condition we need to know about is pregnancy-induced hypertension. So this is high blood pressure, so it's a systolic of above 140 or a diastolic of above 90, or an increase of above booking readings of more than 30 systolic. So say your blood, or 30 systolic or more than 15 diastolic. So say your blood pressure at booking was 110 over 90. However, now you're 25 weeks pregnant and your blood pressure is now 100 and actually that's not a good example because it would still be pregnancy-induced hypertension because it'd be over 150. Okay, say your blood pressure at booking was 90 over 60. No, let's not say 90 over 60. Yeah, 90 over 60, but you're perfectly healthy. And now you're 24 weeks pregnant and your blood pressure is now 130 over 100. That would still count as pregnancy-induced hypertension because your systolic has gone up by more than 30. So even though it's below 140/90, it still counts as pregnancy-induced hypertension because you've got an increase in your systolic of more than 30 above your booking blood pressure. In pregnancy-induced hypertension, you don't have protein in the urine and you don't have edema. This occurs in around 5 to 7% of pregnancies, and typically it resolves after birth, around like a month after. However, this increases your risk of future preeclampsia in the pregnancy and hypertension later on in life. So preeclampsia is pregnancy-induced hypertension with proteinuria, so with more than 0.3 grams more than 0.3 grams in a 24-hour period of proteinuria. Edema may also occur, but it's not included in the criteria for preeclampsia anymore because it's quite non-specific. Like a lot of women get edema during pregnancy. And preeclampsia occurs in around 5% of pregnancies. Okay, so the management of pre-existing hypertension in pregnancy. So investigations that you need to do, you need a baseline renal function and PCR, so that's protein creatinine ratio. You would also do uterine artery Dopplers and growth scan. So the way that it's managed is you need to stop any ACE inhibitors because this causes renal agenesis in the fetus. So this is something you do pre-conception. So if you know that one of your patients has high blood pressure and they're trying to get pregnant, you'd stop the ACE inhibitors. The first choice for pregnant women in managing blood pressure is labetalol, followed by nifedipine and then methyl-dopa. You would also start these women on low-dose aspirin as like a prophylaxis for preeclampsia. So in uncomplicated chronic hypertension, you should be aiming for a blood pressure of 150/100. In hypertension, where you have target organ damage, the target organ being like eyes or kidneys or heart, so if you have target organ damage secondary to chronic hypertension, you should be aiming for a blood pressure of less than 140/90. Postnatally, you should be aiming for blood pressure under 140/90. You should be reviewing the long-term antihypertensive treatments 2 weeks after birth. If the patient was started on methyl-dopa for their hypertension, it's really important that that's stopped within 2 days of birth and you restart their regular antihypertensive medication. This is because I'm pretty sure methyl-dopa, it's associated with postnatal psychiatric problems. I think it's postnatal depression that it's associated with. So that's why I think it might have been postnatal psychosis. It's associated with postnatal psychiatric disorders. That's why it's really important to stop methyl-dopa within 2 days of giving birth. The other thing is you offer women with chronic hypertension a medical review 6 to 8 weeks after birth with the pre-pregnancy care team. Okay, so management of pregnancy-induced hypertension. So if they have mild hypertension, i.e. blood pressure of 140/90 to 149/99, they don't require admission. They don't require any treatment unless they have target organ damage, so kidney disease. Then you might need to be aiming for their blood pressure to be under 140. But if it's pregnancy induced, it's probably not enough time for any target organ damage anyway. You measure their blood pressure once a week, and you should be testing for any protein in their urine at each visit because you're worried about preeclampsia. And then you just do routine blood tests for antenatal care. If they have moderate hypertension, so that's blood pressure between 150 over 100 to 159 over 109, you don't need to admit them. However, you need to start treatment, and the first line is oral labetalol. You need to try and keep the systolic blood pressure below 150 and the diastolic between 80 and 100. You should be measuring their blood pressure at least twice a week, and at every visit you should be testing for protein in the urine. You're going to do blood test, test kidney function, electrolytes, full blood count, and testing liver function as well. For severe hypertension, so this is a blood pressure of above 160 over 110, so 160 over 10 or above, you should admit them until the blood pressure lowers to at least a moderate level. You're going to treat with oral labetalol. You're going to keep the systolic below 150, diastolic between 80 and 100. You're going to measure the blood pressure at least 4 times a day, and you should be checking for protein in the urine daily because they're at an even more higher risk of preeclampsia. You would test at presentation kidney function, electrolytes, full blood count, transaminases, and bilirubin, and then monitor these weekly. With moderate hypertension, you would do those tests, but you don't need to carry out further blood tests if there's no protein in the urine at each subsequent visit. So if you find protein in the urine, then you do those tests. If they have severe hypertension, you're going to monitor those. You're going to do those monitoring blood tests weekly, irrespective of if there's protein or not, with severe hypertension. So, if a woman is receiving outpatient care for pregnancy-induced hypertension after it's been effectively controlled in hospital, so she had severe hypertension, it was reduced to like a moderate level, and now she's receiving outpatient care, you should be measuring her blood pressure, testing her urine twice weekly, so blood pressure and testing urine twice weekly, and carrying out the weekly blood tests, kidney function, electrolytes, FBC, transaminases, bilirubin. In a woman with mild hypertension presenting before 32 weeks or at high risk of preeclampsia, you should be measuring blood pressure and testing urine twice weekly. Okay, so preeclampsia. It's pregnancy-induced hypertension, so new onset and persistent. Proteinuria, so protein in the urine, more than 0.3 grams in 24 hours after 20 weeks of pregnancy. Okay. Edema, we mentioned this already, it used to be the third element, it used to be like a triad, but it's no longer included because it's very non-specific. Preeclampsia predisposes to fetal prematurity, intrauterine growth restriction. It predisposes to eclampsia, which is like tonic-clonic seizures in the mother, which has like a really high morbidity. It predisposes to hemorrhage, so placental abruption and intra-abdominal and intracerebral hemorrhage in the mother. And it also predisposes to cardiac failure and multi-organ failure. Okay, so the risk factors. And risk factors can be split into moderate risk factors and high risk factors. So high risk factors for developing preeclampsia are having hypertensive disease in a previous pregnancy, be it pregnancy-induced hypertension or preeclampsia in a previous pregnancy. Having chronic kidney disease, having an autoimmune disease such as lupus or antiphospholipid syndrome, having type 1 or type 2 diabetes, and having chronic hypertension. So these are high risk factors for preeclampsia. For these women, the way that they're managed is they're given low-dose aspirin daily from 12 weeks until birth. So this is if they have even one of these risk factors. And this is like prophylaxis for preeclampsia. So for the other category is moderate risk factors. So moderate risk factors for developing preeclampsia include it being your first pregnancy, being aged 40 years or older, having an interval of more than 10 years between your current pregnancy and your last pregnancy, having a BMI of 35 or more at your booking visit, having a family history of preeclampsia, or having like a twin or triplet pregnancy, so if it's a multiple pregnancy. So if a woman has more than one moderate risk factor, then she's treated with low-dose aspirin, so 75 milligrams daily from 12 weeks until birth. And that's a prophylactic treatment for preeclampsia. Okay, so the clinical features can be asymptomatic, or it can present with severe frontal headache, problems with the vision such as blurring or flashing before the eyes, severe pain just below the ribs, so right upper quadrant pain or epigastric pain, vomiting and nausea, sudden swelling of the face, hands or feet, hyperreflexia and clonus, reduced urine output, and obviously they'd need to have the diagnostic features of preeclampsia, so high blood pressure and protein in the urine. So the features of severe preeclampsia, typically they have a very high blood pressure, they have higher level of protein in their urine, they present with headaches and visual disturbances, papilledema, they may present with hyperreflexia and a low platelet count, abnormal liver enzymes, which are features of HELLP syndrome, which we'll talk about a bit later on. The consequences of severe preeclampsia are intrauterine growth restriction, intrauterine death, placental abruption, and the maternal complications include eclampsia, hemorrhagic stroke, hemorrhagic or ischemic stroke, pulmonary edema, HELLP syndrome, which is like a hemolytic, so you get a hemolytic anemia, you get elevated liver enzymes and low platelets, disseminated, so DIC as well, you can get in severe preeclampsia, and VTE also seen in preeclampsia, severe preeclampsia. So with management, the definitive management for preeclampsia is delivery of the fetus. But you need to kind of balance this with the risk to the fetus of prematurity. So in the meantime, what's usually done is blood pressure control. So you aim for a blood, okay, this is not right. It's supposed to be aim for less than 160 over 110. And the way this is done is first line is oral labetalol. You could also use an infusion of nifedipine and hydralazine. It's important to note that hydralazine can cause acute hypotension. Or you can use methyl dopa, but it's really important to stop it postnatally because of the risk that we spoke about before. So if a patient comes in with mild hypertension, so their blood pressure is between 140 over 90 to 149 over 99, but they have protein in their urines they have a proteinuria greater than 0.3 grams in a 24-hour period, they need to be admitted because they have preeclampsia, and all patients with preeclampsia need to be admitted. They don't need any treatment for their blood pressure, so they don't need blood pressure control. However, their blood pressure needs to be measured for at least 4 times a day. And you need quantification of the proteinuria. So usually they have like a urine, the urine needs to be collected, and you need to quantify how much protein is in the urine. You need the following tests twice a week. So kidney function, electrolytes, full blood count, transaminases, bilirubin. And the reason why with the transaminase and bilirubin is because you're looking for elevated liver enzymes, full blood count, you're looking for platelets, and hemolytic anemia, which are features of HELLP syndrome. Okay, so moderate hypertension. If they have a blood pressure between 150 over 100 to 159 over 109, they need to be admitted. They need to be treated with oral labetalol. You're going to aim for blood pressure less than 150. You're going to measure their blood pressure at least 4 times a day. Again, quantification of proteinuria, and you're going to do those blood tests 3 times a week rather than 2 times a week. So a patient needs to be admitted to hospital when they have a blood pressure reading greater than 30 over 20 compared to their booking blood pressure. If they have a blood pressure that is greater than 160 over 100 on its own, or if they have a blood pressure that is greater than 140 over 90 and they have proteinuria or growth restriction as shown on an ultrasound scan. Okay, so the management of severe preeclampsia. So these patients need to be admitted. They need to be given oral labetalol, or they might require a labetalol hydralazine infusion. They need to be given seizure prophylaxis, which is magnesium sulfate. But you also need to monitor their magnesium levels because magnesium can lead to respiratory depression. Their systolic blood pressure needs to be kept at less than 150 and diastolic needs to be between 80 and 100. They need blood pressure measurements more than 4 times a day. They need quantification of the proteinuria. You need to be measuring their kidney function, electrolytes, full blood count, transaminases, bilirubin 3 times a week. They need fluid restriction and fluid balance. And if they have presented with severe hypertension, so they have severe preeclampsia after 34 weeks, what you need to do is once you've controlled the blood pressure and you've given them a course of corticosteroids, you should aim for them to give birth. So you should aim to induce labour or carry out a C-section if they're past 34 weeks. So if a woman has preeclampsia with mild or moderate hypertension between 34 to 36 weeks, you would your decision for to induce labour or to carry out a C-section would depend on maternal and fetal condition, any risk factors, and if there's neonatal intensive care available. And if a woman has presented after 37 weeks, because 37 to 42 weeks is considered term, if they presented with preeclampsia, be it with mild or moderate hypertension or severe hypertension, whatever the case is, you are aiming for birth to happen within 24 to 48 hours, because after 37 weeks, there's not really a risk of, there's not a risk of prematurity to the fetus. So at that point, you just want to induce labour or carry out a C-section as soon as possible. Okay, so postnatal management of preeclampsia. The hypertension will resolve spontaneously, but eclampsia, which we're going to speak about in the next slide or so, or maybe the slide after, but eclampsia, like 30% of eclampsia happens postnatally. So it's important that even though the hypertension will resolve spontaneously, that you're still measuring blood pressure at least 4 times a day while the mother is an inpatient, and at least once between day 3 and day 5 after birth. And then if the blood pressure is abnormal between days 3 and 5, you should be measuring on alternate days the blood pressure until normal, until the blood pressure becomes normal. There's often a blood pressure spike between days 2 to 5 after giving birth. After preeclampsia, you should continue antihypertensive, and there's a high risk of recurrence, especially if the mother had severe preeclampsia, which required delivery before 34 weeks. And when I say high risk of recurrence, I mean a high risk of developing preeclampsia in a future pregnancy. And there's a greater risk of cardiovascular disease later in life if you've had preeclampsia. Okay, so eclampsia. It's the development of seizures in association with preeclampsia. And it affects 1 in 2,000 pregnancy. So magnesium sulfate is not just used as prophylaxis, so to prevent seizures, it's also used to treat seizures once they develop. And it should be given once a decision to deliver has been made. So in eclampsia, so if the mother is seizing, you give an IV bolus of 4 grams over 5 to 10 minutes, and then after that, you follow it up with an infusion of 1 gram per hour. You need to be monitoring urine output, reflexes, respiratory rate, O2 sats during treatment, because, especially respiratory rate and O2 sats, because respiratory depression can occur. And if this does occur, then you give calcium gluconate to treat the magnesium-induced respiratory depression. And treatment for eclampsia should continue for 24 hours after the last seizure or 24 hours after delivery. Okay, so HELLP syndrome. It's a life-threatening complication of preeclampsia. It's a triad of hemolysis, so hemolytic anemia, elevated liver enzymes, and low platelet count. Okay, the features are lethargy, right upper quadrant pain, and nausea and vomiting. So as you can see, these symptoms are actually just the symptoms that you'd also see with in preeclampsia. There's nothing like different about them. That's why it's so important to continuously be doing those blood tests, checking transaminases, checking bilirubin, checking FBC to make sure that HELLP syndrome hasn't occurred. And the management is delivery. So pregnancy and epilepsy. We've already spoken about preconception counselling and the importance. We've already spoken about folic acid. We've spoken about aiming for monotherapy. Carbamazepine is the least teratogenic of the older anti-epileptic medications. So the older ones being like phenytoin and that class of drugs. Sodium valproate has like the highest association with neural tube defects, and it's also been associated with neurodevelopmental delay, so it really should be avoided in pregnancy. Phenytoin is associated with cleft palate. Lamotrigine seems to have the lowest rate of congenital malformations, but the dose of lamotrigine may need to be increased in pregnancy. Other important things are vitamin K should be administered to the neonate at birth to prevent hemorrhagic disease of the newborn. The frequency of seizures may increase or decrease during pregnancy. It really depends. And any new seizures need to have other pathology excluded. So the risk of neural tube defects are 3 to 4%. Risk of neural tube defects. So 3 to 4% of newborns born to mothers on anti-epileptic medications have congenital defects. And in terms of the management of an acute seizure, it's the same as you would manage acute seizures in a non-pregnant woman. So lorazepam, it's literally the same management. Okay, so jaundice in pregnancy. So there are a few things that can cause jaundice in pregnancy. So the two that we're going to look at are intrahepatic cholestasis of pregnancy, or obstetric cholestasis, and acute fatty liver of pregnancy. So intrahepatic cholestasis of pregnancy. It occurs in 1% of pregnancies. It's usually seen in the third trimester, and it's caused by a decrease in bile flow. It's the most common liver disease of pregnancy, and the jaundice usually clears within 4 weeks of delivery. The features are itchiness, so especially in the palms and the soles. It's usually worse at night. Mild epigastric pain. There's no rash associated, but you get a raised bilirubin. So the way that it's managed is UDCA, but that's just for symptomatic relief, so to reduce the symptoms of itchiness. You have weekly LFTs to like monitor liver function. And typically, if a woman has obstetric cholestasis, you'll induce labour at 37 weeks or carry out a C-section. The complications are an increased rate of stillbirth. However, it's not generally associated with increased maternal morbidity, so the complications are more really to do with the fetus. So acute fatty liver of pregnancy is a rarer complication, and it may occur in the third trimester or immediately following delivery. So the symptoms are abdominal pain, nausea and vomiting, headache, hypoglycemia, and a severe acute fatty liver may result in preeclampsia. And typically you'll find that ALT is raised significantly in acute fatty liver. So the management is supportive, and once the patient's been stabilised, the definitive management is delivery. Okay, so VTE in pregnancy. So in pregnancy, you have a 4 to 6 times increased risk of developing venous thromboembolisms. It's the leading cause of maternal death, and so for this reason, it's really important to risk assess antenatally and postnatally. So if you're at high risk, i.e. if you've had high risk would mean if you've had a previous venous thromboembolism, you would need treatment, so low molecular weight heparin throughout the antenatal period. There are other risk factors, such as being over the age of 35, having a BMI of 30, having had more than 3 children, being a smoker, being immobile, having current preeclampsia, having a family history of unprovoked VTEs, having low-risk thrombophilia, twin pregnancies, IVF pregnancies, or having gross varicose veins. These are all risk factors for VTE in pregnancy. If you have more than 4 risk factors, so 4 or more risk factors, you require immediate treatment with low molecular weight heparin until 6 weeks postnatally. If you have 3 risk factors, you require low molecular weight heparin from 28 weeks and then continued until 6 weeks postnatally. You would treat suspected clots the same as you would in a non-pregnant woman. If the diagnosis of DVT is made shortly before delivery, you would continue anticoagulation treatment for at least 3 months, as in other patients with provoked DVT. So in a provoked DVT, you continue anticoagulation for 3 months at least. Okay, so Hyperemesis gravidarum. It's a severe form of, we're going through all these different diseases that are associated with pregnancy. So the next one we're going on to is Hyperemesis gravidarum. It's a severe form of morning sickness with unrelenting, excessive pregnancy-related nausea and vomiting, and the key feature is that it prevents adequate food and fluid intake. So it's seen in about 1% of pregnancies. It's thought to be related to increased beta-HCG levels, and it's most common between 8 to 12 weeks, but it can persist in some women to up to 20 weeks. So it's a triad of 5% or more pre-pregnancy weight loss, dehydration, and electrolyte imbalance. So it's seen more in multiple pregnancies, so in twin pregnancies, in trophoblastic disease, in hyperthyroidism, in women who have not previously given birth, and in obesity. So the point at which you might consider admitting a pregnant woman with hyperemesis gravidarum is if they have continued nausea and vomiting and they're unable to keep down liquids or oral antiemetics. Or if they have continued nausea and vomiting with ketonuria, so if they have ketones in their urine and or weight loss greater than 5% of their body weight, despite treatment with oral antiemetics. Or you might consider keeping them, you might consider admitting them if they have a confirmed or suspected comorbidity. So if they have hyperemesis gravidarum and also they're diabetic, you might consider keeping them in because it's more important for them to maintain like their fluid levels because they're an increased risk because of another comorbidity. Okay, so management. So the first line antiemetic are antihistamines, so cyclizine or promethazine. Second line are ondansetron and metoclopramide. Other things that you can recommend are ginger. So ginger is quite good for as an antiemetic. Also, you can try acupressure as well. So P6 at the wrist can be tried. We've already mentioned that admission might be required for IV hydration and vitamin B supplements and folic acid. So the complications of hyperemesis gravidarum are really to do with the loss of nutrition. So the first one, Wernicke's encephalopathy, is to do with the loss of nutrition. So you can develop Wernicke's encephalopathy if you're losing vitamin B. Mallory-Weiss tear is from the is like a tear in the esophagus, a tear in the esophageal vessels because of the continuous vomiting can lead to a tear. Central pontine myelinolysis, which is to do with the loss of nutrition. You can get acute tubular necrosis to do with loss of to do with dehydration. And the effects it can have on the fetus are you can have a fetus that's small for gestational age or preterm. Okay. So the next thing we're going to go on to speak about is antepartum hemorrhage. Okay. So antepartum hemorrhage is any bleeding from the genital tract after 24 weeks pregnancy. So any bleeding from 24 weeks pregnancy to just before delivery of fetus. If a woman presents, say you're in primary care and a woman presents with bleeding after 24 weeks pregnancy, it's really important that you don't carry out a vaginal examination, because this could, if it turns out that they have placenta previa, this may trigger hemorrhage, so an increase in bleeding. Okay, so the two that we're going to talk about are placental abruption and placenta previa. So placental abruption is when you get separation of a normally sited placenta, so the placenta is in the right place, but you get separation of it from the uterine wall. This can lead to maternal hemorrhage, and this maternal hemorrhage into the space can either be revealed abruption or it can be concealed. So in a revealed abruption, you get blood trickling down the membrane and the myometrium, presenting as an antepartum hemorrhage. In a concealed one, however, in a concealed placental abruption, the blood kind of collects and enters the myometrium rather than presenting as antepartum hemorrhage. This can occur in 1 in 200. This occurs in 1 in 200 pregnancies, and there are certain things that are associated with placental abruption, such as preeclampsia, multiparity, maternal trauma, increasing maternal age, cocaine use, uterine overdistension. So this could be because of like a multiple pregnancy, it's overdistension of the uterus. Tobacco use, previous placental abruption, or intrauterine growth restriction, or an autoimmune disease. All of these things are associated with placental abruption. The features of placental abruption are, so the first thing is sudden onset abdominal pain. So this is an important distinction to make from placenta previa. In placental abruption, you get antepartum hemorrhage, so some, not always, but with the bleeding you get pain. So it's painful bleeding, whereas in placenta previa you get bleeding that's painless. So you get this sudden onset abdominal pain in the third trimester. It's a constant lower abdominal pain. You get a shock that's out of keeping with, you might get a shock which is out of keeping with visible loss. So a patient might be in hypervolemic shock, so mother might have a low blood pressure, and they might be cold and clammy and sweaty, but the amount of blood that they're losing doesn't match up with the shock that they're in, and that's because the blood may be collecting in the myometrium rather than being revealed. They may present with a woody, hard, tense, tender uterus. Usually they have like a normal lie and presentation, and the fetal heart would, so on the CTG may show like a distressed fetal heart, may show fetal distress, and they may have coagulation problems. So PV bleeding, so vaginal bleeding is not always present in placental abruption. With placenta previa, the placenta is lying low. So it's either lying wholly or partly in the lower uterine segment. And we've spoken about this already, like 5% of women may have a low-lying placenta on the 20-week scan, but then for the majority it kind of moves up. The placenta moves up by 34 weeks. So the incidence at delivery of placenta previa is only 0.5%. So yeah, most placentas rise away from the cervix. So the factors that are associated with placenta previa include multiparity, multiple pregnancy, and also if you have a previous C-section, embryos are more likely to implant on a lower segment scar from a previous C-section, so that would increase your risk as well. So the features, you have like a hypervolemic shock, which is in proportion to the visible loss. It's a painless bleeding. The uterus is not tender. The lie-in presentation may be abnormal. The fetal heart is usually normal, so it's not usually any signs of distress as such. You don't usually get coagulation problems, and it's usually that you get a small bleed before a larger bleed. So placenta previa can be graded. So 4 grades. The 4th grade, so grade 4 being where the placenta completely covers the internal os. Then you have grade 3, which is where the placenta covers the internal os before dilation, but not when fully dilated. Or you have grade 2, where the placenta reaches the internal os, but it doesn't cover it. And then you have grade 1, where the placenta reaches the lower segment, but not the internal os. Okay, so we've got 2, oh dear, okay. This is the wrong way round. This this placenta previa is this one. So as you can see, the placenta is on the lower segment of the uterus here. So this is a major one, where it's covering the internal os. And this one is marginal placenta previa, so it's on the lower segment, but it's not covering the os. This is placental abruption. So A, you have a revealed abruption because the blood is kind of is escaping, and so you'll see a hemorrhage. So it'll present with hemorrhage. Then you've got concealed abruptions, and this is where the blood is kind of collecting in the myometrium, and you get like a woody, hard, tense, painful uterus. Okay, so the management of each of these. So first, the complications of placental abruption. So the complications include hemorrhage, so postpartum hemorrhage, DIC, renal failure, and fetal death. With placenta previa, the complications include, because the internal os is being obstructed, so it could obstruct head engagement, so it could mean that you don't get engagement, therefore you may require a C-section. You may get hemorrhage with placenta previa. You may get placenta accreta, which is where the placental villi attaches to the myometrium and you're unable to separate it. This could lead to difficulties, especially when it comes to the third stage of labour in removing the placenta. It might result in needing a hysterectomy with a placenta accreta. It's quite serious. Or you can get placenta increta, which is where the placenta villi invades the myometrium, or placenta percreta, which is where the placenta villi perforates the myometrium into the surrounding tissues like bladder. So it's getting more severe as you go along, each of those. Here's the way it's investigated. With placenta previa, you investigate it using an ultrasound scan. It's really important, again, you don't do a vaginal examination in primary care if you suspect placenta previa. With placental abruption, the diagnosis is usually clinical. You can also use CTG to look for fetal distress. To look for maternal well-being, you're going to check FBC, coagulation screen, because you can get coagulopathy with placental abruption. You're going to do a cross match, and you're going to do catheterization with an hourly urine output. That really, I'd say, actually, this bit comes into management more than investigations. But anyways, the management for each of these. So if we start with placental abruption, they need admission. If there's no fetal distress and they're less than 37 weeks, you can just monitor because you're worried about the risk of prematurity to the fetus. And if they're not distressed and they're under 37 weeks, you can just continue to monitor. If they're over 37 weeks and they're not distressed, there's no risk of prematurity, so you can just induce labour and deliver the baby, or do a C-section. If the fetus is distressed, you're going to do an urgent C-section. And if the fetus has passed away, if the fetus is dead, then you would give blood and you would induce labour. Okay, so for placenta previa, the management, so we've already spoken about this. So you'd rescan at 34 weeks. There's no need at this point to limit activity or intercourse unless there's bleeding. If it's still present at 34 weeks and it's grade 1 or 2, so if you remember grade 1 and 2, it doesn't cover the os. It doesn't cover the os. Then if it's grade 1 or 2, what you do is you'd scan every 2 weeks. If there's an abnormal lie or a high presenting part, so basically the head isn't engaged or there's an abnormal lie at 37 weeks, a C-section should be performed. If there's bleeding, you need to admit the patient, you need to treat the shock and cross-match blood. You have a final ultrasound scan at 36 to 37 weeks to determine the method of delivery. Sorry, this is in odd order, but what you do is for a C-section, for grades 3 to 4, because the internal os is being obstructed, you would need to do a C-section between 37 to 38 weeks for grades 3 to 4 placenta previa. If they're grade 1, because the os isn't covered, you can do a vaginal delivery. Okay. So other causes of antepartum hemorrhage. So uterine rupture. This usually occurs during labour, but can occur before labour in women who have a scarred or congenitally abnormal uterus. And the risk factor for this is having a previous C-section. And it's also the reason why after you've had 2 C-sections, you go straight for, if you're pregnant again, you go straight for a 3rd C-section. You don't try for a vaginal delivery because of the risk of uterine rupture, because you've had previous C-sections. So the way that it presents is maternal shock, so hypovolemic shock, abdominal pain, and vaginal bleeding to varying degrees. So vasa previa occurs when the fetal blood vessels, which run in the membranes in the front of the presenting, occurs when the fetal blood vessels run in the membranes in the front of the presenting part. What this is basically you get a rupture of the membranes, and then you get vaginal bleeding. The bleeding is from where the fetal blood vessels have run in the membrane. And in this, you classically get fetal bradycardia. So it's painless moderate vaginal bleeding after the rupture of the membranes. Or you can get spontaneous rupture of membranes, which is followed by severe fetal distress, so fetal bradycardia, because the membranes have ruptured, and then because the fetal blood vessels were running in that membrane, they've kind of ruptured, and so you get that bleeding, and that's why you get fetal distress. Unfortunately, like with vasa previa, C-section is often not fast enough to save the fetus. And vasa previa doesn't carry any major maternal risk. The risk for fetal mortality, though, is very high. Okay, so there are different ways that you can monitor fetal well-being. So the first is an ultrasound scan, and so with an ultrasound scan you can measure biparietal diameter, so that kind of gives you an idea about the growth of the fetus. Other things that you can look at are femur length, head circumference, and transabdominal circumference. So these are all measurements of growth, and they can give you an idea as to whether there's any intrauterine growth restriction. Another thing that you can measure is intrauterine amniotic fluid volume, and this is really good. This is really used for fetal well-being in the 3rd trimester. It gives you an amniotic fluid index with 8 to 18 being normal. If you have an AFI less than 5 to 6, that signifies oligohydramnios, and that could be either secondary to excess loss of fluid or a decrease in fetal urine production or excretion. So it could be a problem with the fetal kidneys. Or you can get an AFI of over 20 to 24, and that signifies polyhydramnios, which is linked to fetal abnormality. So it could be an absence of swallowing or a blockage in the fetal GI tract. Okay, so intrauterine growth restriction, it's a failure to reach normal growth. There's 5% incidence and a 1% risk of stillbirth. So the causes, you can split the causes into maternal, placental, and fetal. So some of the maternal causes might be undernutrition, smoking or the use of drugs, increased age, hypertension, diabetes, and renal disease. So these are maternal causes. Placental causes include infarcts or hemorrhages, vascular anomalies, and incomplete trophoblastic invasion. And then you have fetal causes. So if you have multiple pregnancies, the increased risk of intrauterine growth restriction, congenital infections, so CMV and rubella, and chromosomal abnormalities as well can lead to intrauterine growth restriction. You can subcategorize intrauterine growth restriction into symmetrical and asymmetrical. So in symmetrical, the head circumference, both the head circumference and the abdominal circumference are reduced. So that means that they're going to, the brain development has been affected in symmetrical. And it usually presents earlier. So the things that cause symmetrical IUGR are the torch infections. So those are like toxoplasmosis, rubella, CMV, and HIV. Substance misuse, so alcohol and heroin, and trisomy 13 and trisomy 18. So these are like chromosomal abnormalities. And the things that cause asymmetrical intrauterine growth restriction. So this is where the head circumference is preserved, but at the expense of like the development of the liver. So this usually occurs. Asymmetrical IUGR is usually caused by preeclampsia and placental insufficiency. Okay, and the next thing we're going to talk about are the causes of oligohydramnios and polyhydramnios. So the causes of oligohydramnios: fetal renal problems, so renal agenesis, which we mentioned can be caused by use of ACE inhibitors during pregnancy, intrauterine growth restriction, post-term gestation, preeclampsia, maternal dehydration, drug-induced, we've already said ACE inhibitors, indomethacin, preterm rupture of the membranes, twin-to-twin transfusion syndrome, and uteroplacental insufficiency. So these are all things that can cause oligohydramnios. Things that can cause polyhydramnios, we've mentioned some of these before, so fetal macrosomia, gestational diabetes, maternal age, multiple pregnancy, gut atresia, and transesophageal fistula. Okay, and then the third method of monitoring fetal well-being is the cardiotocography, so CTG. It's a continuous tracing of the fetal heart rate. It measures the fetal heart rate along with the times of uterine contractions. You can see uterine contractions along the bottom here. So the baseline heart rate is this here, and it will vary. So it will go kind of up and down, but it should be between 110 to 160. So anything above that, so above 170, is a tachycardia, and that could be caused by maternal or fetal infection. It could be caused by acute fetal hypoxia, or fetal anemia, or any drugs. And bradycardia, so less than 100, is abnormal, and that could be caused by hypoxia again, cord compression, or placental abruption. So the way that you interpret a CTG, and I would recommend, because I haven't been able to put it into this lecture because there's just so much to cover, but I would really recommend looking up online. I think Geeky Medics has something on interpreting CTGs, but I would recommend taking some time out to practice reading CTGs, and also on your placements. If you ask one of the midwives to go through it with you, I think it's really useful. So the way that you would interpret it is using this acronym. So Dr. C Bravado. So DR being define the risk. So is there any maternal medical illness, e.g. Diabetes or hypertension, maternal sepsis, Then you look at the contractions. So the contractions, it really, I've said normal is 2 in 10 minutes, but it really depends on how far along in labour you are. And then BRA is the baseline rate, so that should be between 110 to 160. Then variability, so variability in the heart rate should be between 5 and 25. You can get accelerations, which are more than 15 beats per minute. And these are usually normal, and they're usually timed in with, they're usually due to fetal movement. So any accelerations are normal, typically. And then you get decelerations. Decelerations, if they occur early, it's usually because when we say they occur early, they occur in time with uterine contractions. That's normal. And they kind of recover when the contraction stops. These are referred to as early decelerations, and they're normal and non-pathological. You then get variable decelerations, which are usually indicative of cord compression, and then you get late decelerations or prolonged decelerations, which are usually a sign like of fetal distress. So they're, yep. And then afterwards, you kind of have your overall assessment. So if you're suspicious, if you think that they need further monitoring, if you think it's pathological and actually it means that you need to consider an emergency C-section, or if everything's normal. So that's kind of how you read CTG. But yeah, definitely spend some time going over that, I'd say. Okay, so induction of labour. The indication, so induction of labour is basically inducing labour artificially. So there's different ways that you can do this. We'll first start with why you would do it. So the indications for doing it. Prolonged pregnancy, so after 12, if it's been more than 12 days since your estimated date of delivery and you still haven't given birth, then you might induce labour. Where you've got premature rupture of the membranes, however labour hasn't started, then you may induce labour. In diabetic mothers, you would induce labour if they haven't given birth after 38 weeks because of the risk of macrosomia and polyhydramnios. You'd want to induce labour at 38 weeks. In rhesus incompatibility, you may induce labour, and also in preeclampsia. The methods. So the first method is membrane sweep, and that's where you insert a finger into the vagina and you kind of sweep over the head, and so you sweep to kind of separate the membrane from the cervix, if you can see. So that's it before the membrane sweep, and that's afterwards. You can induce labour using intravaginal prostaglandins, or by artificially breaking the waters using an amnio hook, which is what they're doing there. So that's also known as an amniotomy, or you can induce labour with oxytocin. Okay, so what is labour? So labour is the onset of regular, painful contractions associated with cervical dilation and descent of the presenting part. So signs of labour: regular, painful uterine contractions, so the shedding of the mucus plug. Rupture of membranes, again, it doesn't always happen. Shortening and dilation of the cervix. Yeah, those are the signs of labour. Normal labour begins spontaneously between 37 and 42 weeks. So anything before this is preterm, and everything after this is postterm. So 3 stages of labour. First stage is from the onset of true labour. So the onset of, regular painful contractions, shedding of the mucus plug, etc. So from that onset until when the cervix is fully dilated. That's first stage of labour. The second stage of labour is the pushing stage. Okay, so it's from full dilation to the delivery of the fetus. And then the third stage is from delivery to when the placenta and membranes have been completely delivered. So from the delivery of the baby until when the placenta and the membranes have been completely delivered. So monitoring during labour. Fetal heart rate is monitored every 15 minutes, or if it's a high risk labour, you might continuously monitor it using CTG, cardiotocography. And fetal heart rate can be otherwise monitored every 15 minutes using a sonic aid. Contractions are assessed every 30 minutes. Maternal pulse rate is assessed every hour. Maternal blood pressure and temperature should be checked every 4 hours. And a vaginal examination is offered every 4 hours to check the progression of labour. It's not done more than every 4 hours because you don't want to increase the risk of infection, which can lead to chorioamnitis. But we'll talk about that later. And then maternal urine should be checked for ketones and protein every 4 hours because of preeclampsia. Okay, so the first stage of pre-labor. So before the onset of the first stage of labor. Some women get Braxton Hicks contractions, which are non-painful, like practice contractions late in pregnancy. You might get a show or mucus plug being discharged, so it's like a small amount of blood-stained discharge. You might get rupture of the membranes. If you don't, you can get an induction of labour. So you might get rupture of membranes beforehand. If you get rupture of membranes, but then so if your water breaks, but then you don't get an onset of labour, then you might need to be induced if labour hasn't started within 24 hours, and the reason for this is to reduce the risk of infection. Okay, a Bishop's score is important to know for exams. So it's a pre-labour scoring system, and basically it is useful in predicting whether you'll need to induce labour or not. So a score of less than 5 indicates that labour is unlikely to start without induction, and a score of more than 9 indicates that labour will most likely commence spontaneously. So the different, I'd say the important thing to know is the different criteria. So cervical position, cervical consistency, cervical effacement, and cervical dilation. And fetal station, sorry. Okay, so stage 1 of labour. You get regular, painful rhythmic contractions. There are 2 main phases in stage 1. First is the latent phase, and that is the time in which you get the first 3 centimeters of dilation. It usually takes around 4 to 8 hours. And the cervix in this time is dilating quite slowly. You get around 2 to 3 mild contractions every 10 minutes, and they last about 20 seconds. In the active, remember this is all, I'm giving these figures, but it really varies from woman to woman, and you find that in women that have given birth previously, in women that have had previous pregnancies and given birth previously, these times might be a lot quicker than in women who are preemies, so women that have given birth for the first time. So the active phase is between 3 centimeters to 10 centimeters, 10 centimeters being fully dilated. So it's that time period is the active phase, and the cervix is at this time dilating at a rate of 1 centimeter or more an hour, and women are getting 3 contractions every 10 minutes usually in this time. It's at this point, so what often happens is a woman goes into labour, however, when she gets to hospital, they may tell her to come back when her contractions are more regular. So when they're occurring, 3 times every 10 minutes. So usually women are admitted to hospital when they have when they're having contractions every 3 minutes that are equal in length and intensity, irrespective of position. Okay, so it's really when you're getting contractions more regularly, and you're closer to and you're in the active phase basically of labour. That's when when women are usually admitted to hospital, because you're closer to the stage 2 of labour. In stage 1, it's really important to eat and drink and mobilise as much as possible. Effacement is basically the thinning of or the ripening of the cervix. And what happens is the cervix, so if you can see here, the cervix is not effaced and it's not dilated at all. Here, it's fully effaced, it's thinned, the cervix has thinned. And that's what we mean by effacement. So the effacement is a gradual thinning and shortening and drawing up of the cervix. Dilation goes from 0 to 10%, and it's when you can no longer, so on vaginal examination, you can't feel any cervix around the fetal head. That's when you know that the mother is fully dilated. And after full dilation, what happens is the head flexes further and descends further into the pelvis. Okay, stage 2. Stage 2 is from full dilation to the delivery of the fetus. So there's 2 main stages. You have the passive second stage, which refers to the second stage, but in the absence of pushing. And then you have the active second stage, which is the active process of maternal pushing. So stage 2 is actually less painful than the first stage, because the pushing kind of masks the pain, and it lasts approximately 1 hour. If it goes over 1 hour, if it's lasting longer than 1 hour, then you might consider an instrumental delivery, such as with like a ventouse extraction or forceps delivery. Or you may consider a C-section. An episiotomy, which is like a cut that's made in the perineum, may be necessary following crowning to like allow for ease of passage. And stage 2, so the pushing stage, is associated with transient fetal bradycardia. So you can see here the presentation of the head. You get rotation of the and delivery of the anterior shoulder, delivery of the posterior shoulder, and then delivery of the lower body, the umbilical cord. So different stages of different parts of stage 2. Okay, stage 3. This is the delivery of the placenta. Typically it takes 15 to 30 minutes. Normal blood loss is less than 500 mils. Anything above that is considered postpartum hemorrhage. So in this stage you get active management. What happens is you defer clamping and cutting the cord for over 1 minute after delivery, but less than 5 minutes. The way that you get the placenta out is through controlled cord contraction after you get signs of placental separation. The signs of placental separation are the cord, the umbilical cord lengthening and getting a gush of vaginal blood. Then you can carry out cord contraction to pull to remove the placenta. Women are given oxytocin by IM injection after delivery, and this is to reduce the risk of postpartum hemorrhage. So prolonged third stage of labour would be is when you're unable to deliver the placenta within 30 minutes of fetus delivery. And so the first step in the management is 10 units of syntocin, and then if after another 30 minutes, so 1 hour post-delivery not delivered, then you'd need to manually extract the placenta. Okay, so perineal trauma. 85% of women experience perineal trauma. It's usually repaired after delivery of the placenta, so you have 3 different degrees. So first degree, it's a laceration that's limited to superficial skin or vaginal mucosa, and it's got no involvement of any muscles. Second degree affects the skin and also perineal muscles, but it doesn't include the anal sphincter. In the third degree tear, you get a tear that's affecting the skin, perineal muscles, and the anal sphincter is also torn. And then you can subdivide that into a partial tear of the external anal sphincter involving less than 50% or more than 50% of the external sphincter. And then in 3C, you get the internal sphincter that's also torn. And then in fourth degree, you get perineal skin affected, perineal muscles, external and internal anal sphincter, and also rectal mucosa is torn. So it's different degrees of tears. Okay. 3 P's of labour. So these are the main causes of obstructed labour. So the first one being power. So this is where you're getting inadequate contractions. This could be because because of maternal exhaustion, for instance. So the way that it's managed is you can have an amniotomy, which accelerates labour from the latent to active phase, and this is done using an amnio hook. Syntocin infusion, which you can administer to increase the power of the contractions. However, you need to avoid, you need to kind of titrate it so that you're not getting more than 3 contractions every 10 minutes, because if you get hyperstimulation, it could increase the risk of uterine rupture. The next P is passage. So the examples of problems with passage would be cephalopelvic disproportion. So if the pelvis is too small to allow the head to pass, in this case you might need to go opt for a C-section. Any pelvic masses or pelvic variants or deformities which obstruct the passage of delivery, cervical incompetence, placenta previa or soft tissue tumours. The way that it would be managed would be through a C-section, for instance, or a episiotomy, which is an incision through the perineum to enlarge the vagina during the second stage. And the cut is usually done laterally, so posteriorly and laterally, so at the 7 p.m. position, to avoid cutting through, to avoid cutting through the sphincters, and which could cause pelvic floor dysfunction. Okay, passenger, so this is to do with the presenting part of the fetus. So any fetal abnormalities as well, so breech being breech or transverse lie, and multiple pregnancies as well. Okay, so abnormal labour. So the way that it's managed, so this is more to do with the different things that can go wrong in each stage. So you can have a failed induction, you can have slow progress, so this is in stage 1, failed induction, slow progress, fetal distress, and that might mean that you need to progress to a C-section. In stage 2, again, you may have failure to progress, you may have maternal or fetal distress, and you may need to try an instrumental delivery or C-section. Stage 3, you can get postpartum hemorrhage, uterine inversion and amniotic fluid embolism, retained products, uterine atony, which is basically where the uterus doesn't contract after delivery, and so it can lead to, it's the #1 cause of postpartum hemorrhage, or soft tissue lacerations. Okay, so C-sections. There are two main types: lower segment C-section and classic Cesarean section. Classic Cesarean section, very rarely seen nowadays. Lower segment C-section is what makes up like 99% of cases. I've outlined some of the risks of C-sections, and also so I've outlined the serious risks of C-sections. So the serious ones are less common, and then I've also outlined some frequently seen risks. So the frequently seen risks are like infections, so like wound infections, endometritis, UTIs, increased risk of repeat C-sections and subsequent pregnancies, and abdominal discomfort in the first few months after surgeries. And to the fetus, you might get lacerations, and this happens in 1 to 2 babies in every 100 C-sections. And the serious risks of C-sections are like things like an emergency hysterectomy, injury to like the ureter or the bladder, death, but this is like in 1 in 12,000 cases. C-sections can be categorized into 4. So you can have an elective C-section, which is like where it's decided, the delivery time is decided beforehand. It's done to suit the mother and the staff. Or you can have emergency C-section, which is done like because there's an immediate threat to the life of the mother or fetus. Then you have like the next category down is where is like danger, where there's maternal or fetal compromise, but it's not like an immediate life-threatening situation, or there's no danger, but you need an early delivery, and there's no maternal or fetal compromise. So the indications for an elective C-section: abnormal position, failed external cephalic version, placenta previa, having more than 2 previous C-sections, or multiple pregnancy with the first twin that's breech. Okay, indications for an emergency C-section: fetal distress, severe APH, so severe antepartum hemorrhage, undiagnosed breech, so if you only find out about breech that the baby's breech very late on, cord prolapse, prolonged labour with no progress, eclampsia, failed induction of labour. If you have had a previous C-section and the signs of impending rupture, uterine rupture, these are all reasons that you'd have an emergency C-section. Okay, instrumental delivery. The conditions needed for an instrumental delivery are being fully dilated, for the fetal station to be 0, to have you need to have ruptured membranes, empty bladder, otherwise the bladder will tear, you need to be pain-free, and you need a specialist to be carrying it out. So there's 2 types of instrumental delivery. You have ventouse, which is like where you get a rubber or metal cap, and it's like you apply suction, and the cap is attached to the fetus head, and it occurs during maternal pushing, and it allows the shape of the pelvis to simultaneously rotate a malpositioned head to OA. So if the baby's not in OA, you can rotate at the same time. Okay, so forceps, you have non-rotational forceps and rotational forceps. So non-rotational have a cephalic curve for the head and a pelvic curve which follow the sacral curve, and they grip the head in whatever position, and it allows for traction. And it's only suitable if the baby's head is in OA position. And rotational forceps have no pelvic curve, and they enable a malpositioned head to be rotated to OA before traction is applied. So non-rotational are these 2, and rotational is this one. Okay, postpartum hemorrhage. You can have primary or secondary postpartum hemorrhage. Secondary occurs between 24 hours and 12 weeks of giving birth. It's due to retained placental tissue or endometritis. Primary postpartum hemorrhage Occurs within 24 hours. It affects 5 to 7% of deliveries, and the most common cause is uterine atony. So I've just listed some of the risk factors here. The way it's managed is syntocin, so oxytocin, or ergometrin. If that doesn't work, first-line surgical intervention is an intrauterine balloon tamponade, but this can only be used where uterine atony is the only or main cause of hemorrhage. Other options are B-Lynch suture or ligation of the uterine arteries. If severe and uncontrolled, then you may require the mother may require hysterectomy, and it's performed as like a life-saving procedure. Okay, amniotic fluid embolism. So this is where fetal cells or amniotic fluid enters the mother's bloodstream. It causes sudden dyspnea, hypoxia, hypotension, and seizures. It's a very rare complication of pregnancy, but it's associated with a very high mortality rate. There seems to be a link with maternal age and induction of labour, so these two things seem to be associated with amniotic fluid embolism. The symptoms are chills, shivering, sweating, anxiety, coughing. The signs are cyanosis, hypotension, bronchospasms, tachycardia, arrhythmia, and MI. The way that it's diagnosed is it's a diagnosis of exclusion. There are no definitive diagnostic tests for it, and the way that it's managed is through resus, because of the hypotensive, so resuscitation fluids, and supportive management. Okay, shoulder dystocia. So it's the inability to deliver the body of the fetus using gentle traction, and it's due to impaction of the anterior fetal shoulder on the maternal pubic symphysis, okay, as you can see there. It's an obstetric emergency as the umbilical cord is compressed in the vagina, and it's a cause of both maternal and fetal morbidity. It's associated with postpartum hemorrhage, perineal tears, and brachial plexus injury. So the key risk factors are gestational diabetes, because it leads to fetal macrosomia, prolonged labour, and also high maternal BMI. So the management, as soon as it's identified, you need to call for help. The first thing that's tried is McRoberts manoeuvre, and so that's where the mother flexes and abducts her hips, so that's bringing the thighs towards the abdomen. And the reason why this is done is it increases the relative AP angle of the pelvis, and often it's successful in facilitating delivery. An episiotomy will not relieve the bony obstruction, but it may allow for better access to internal manoeuvres. So basically, you can do an episiotomy, but that's not going to relieve the place where the shoulder's gotten stuck. But it may allow for you to kind of access, like to internally manoeuvre the fetus. Cord prolapse. So cord prolapse is where the cord presents before the presenting part during labour. One of the signs of it is sudden decelerations on CTG. It occurs in 1 in 500 deliveries. If left untreated, it can lead to compression of the cord or cord spasm, which leads to fetal hypoxia and eventually irreversible damage or death. So the majority of cord prolapses occur at artificial rupture of membranes. The diagnosis is made when you notice that the fetal heart rate is abnormal, or the cord is palpable vaginally, or if the cord is visible beyond the level of the opening of the vagina. So the risk factors: prematurity, cephalopelvic disproportion, multiparity, a long umbilical cord, twin pregnancy, polyhydramnios, abnormal presentation or high fetal station. The way that it's managed, so the presenting part of the fetus may be pushed back into the uterus to avoid compression. So it's really important that you don't try and push the cord back inside, because overhandling the cord can lead to cord spasm, which can reduce the blood flow to the fetus and cause fetal hypoxia. So what's usually done is if the cord is past the level of the vaginal opening, it should be kept warm and moist, and it shouldn't be pushed back inside. At this point, the mother is asked to go onto all fours, and this kind of is done so that you can prepare for an immediate C-section to be carried out. An instrumental vaginal delivery is possible if the cervix is fully dilated and the head is low, but usually it is an immediate C-section. Okay, so preterm labour. Preterm labour is delivery between 24 and 37 weeks. Neonatal risk is greatest before 34 weeks. The reasons why it happens: if there's too much inside, so if it's multiple pregnancies or polyhydramnios, this can trigger preterm labour. If the fetus wants to escape, so if there's intrauterine growth restriction or preeclampsia, that can cause that can lead to preterm labour. So this is like where you would induce actually preterm labour because of risk to mother and risk to fetus. Weak wall, so cervical incompetence. This can sometimes happen, especially in women who've had a loop excision. So it's a form of treatment for cervical intraepithelial neoplasia. It can lead to cervical incompetence, and that might lead to having that might cause preterm labour, or infection, so bacteria in and around the wall. So the way it's diagnosed is fetal fibronectin test. This test can be repeated weekly for those who remain high at risk. Fetal fibronectin is a protein that kind of keeps the amniotic sac glued to the uterus lining, and if preterm delivery is likely to occur, what you get is like a leakage of this into the vagina. So a positive test is inconclusive. You can't confirm anything with a positive test. However, a negative test has a high negative predictive value. So if you have a negative fetal fibronectin test, it's very unlikely that you will go into preterm labour within the next 7 to 10 days. And if a mother does go into preterm labour, it's really important to give steroids. If you are planning for a woman to give birth before 34 weeks, it's really important to give steroids at 24 to 34 weeks to promote pulmonary maturity in the fetus. Okay, APGAR score is a scoring system which is used after delivery to kind of assess the health of the baby. And so APGAR stands for appearance, pulse, grimace, activity, respiration, and it's important to learn this for exams. Okay, preterm pre-labour rupture of membranes. This occurs in 2% of pregnancies, but it's associated with 40% of preterm deliveries. So the complications are prematurity, infection, and underdeveloped lungs. And in the mother, the risk is chorioamnionitis, which we'll speak about a bit later. So the investigations. A sterile speculum examination should be conducted. However, you shouldn't really conduct digital examinations because of the risk of infection. Ultrasounds may be useful to show oligohydramnios. The way it's managed is if you have preterm pre-labour rupture of membranes, the mother should be admitted. You should have regular observations, so checking the temperature regularly, checking blood pressure, heart rate, all of that to ensure chorioamnionitis is not developing. They should have oral erythromycin for 10 days. You should give antenatal corticosteroids to reduce the risk of respiratory distress syndrome and to help with pulmonary development in the fetus. Delivery should be considered at 34 weeks of gestation. So there's this trade-off between the increased risk of maternal chorioamnionitis with the decreased risk of respiratory distress syndrome as the pregnancy progresses. I don't think I actually talk about chorioamnionitis, but it's basically a severe infection that has like a high morbidity in women, in pregnant women, when it develops, and it requires IV antibiotics. Okay. Multiple pregnancies. So the incidence of twins is obviously much higher than triplets. Twins may be dizygotic, so these are non-identical. They develop from two separate ova which were fertilized at the same time. Or monozygotic. Monozygotic are identical twins. They develop from a single ovum, and they have a single ovum which has divided to form two embryos. Okay. So the rate, the monozygotic twin rate is fairly constant. However, dizygotic twin rates are influenced by race. So, for instance, in Nigerian Yoruban women, it's the rates of dizygotic twins is like 1 in 23, which is very high. Increasing maternal age, previous twins, so if twins run in your family, you're more likely to have twins. Multigravida, and also in induced ovulation, so IVF as well. Okay, so amnionicity is the number of amnions, so the number of inner membranes surrounding the fetus. Chorionicity is the number of placentas, so the number of outer membranes. So dizygotic twins are 100% dichorionic. So dizygotic twins each have their own placenta. Monozygotic twins, 2/3 of them share a placenta and 1/3 are dichorionic. You'll see that monochorionic twins are associated with more complications. There's an increased risk with monochorionic twins. And this diagram here just kind of shows how the amnionicity and the chorionicity is all dependent on when you have cleavage of the embryo in monozygotic twins. Okay, so the features of multiple pregnancies. So in early pregnancy, the uterus is large for dates. You're more likely to have hyperemesis gravidarum in multiple pregnancies. You get polyhydramnios later. Signs. You can feel 2 pulse or 2 fetal heart rates are heard. And an ultrasound scan at 12 weeks can confirm whether you have multiple pregnancies. And for monozygotic twins, it can distinguish between monochorionic and dichorionic twins by the placental masses. So you can see a lambda sign here, or a twin peak sign, and this suggests dichorionic twins, so they have separate placentas. Or you have the T sign, so there's an absence of this twin peak sign, and that suggests monochorionic pregnancy, so they're sharing one placenta. So complications of multiple pregnancies. Okay, so the higher incidence of APH. Anemia is more common. There's a greater risk of preeclampsia. There's a greater risk of UTIs. You get more nausea and vomiting, so these are all antenatal complications. Fetal complications. In monochorionic pregnancies, you can have twin-to-twin fetal transfusion, which we'll go over in a later slide. They're usually lighter for dates. You can get growth restriction, increased rates of malformations, especially in monozygotic twins. Prematurity is more common. Perinatal mortality is increased 5-fold. And then in terms of labour complications, postpartum hemorrhage is more common, malpresentation is more common, vasoprevia is more common, cord prolapse is more common, and premature placental separation and cord entanglement, especially in monoamniotic twins, may occur. Okay, twin-to-twin transfusion syndrome. This is where you get a vascular anastomosis in placental beds, which leads to net transfer of blood from one twin to another. Okay, so you can see what's happening here from this anastomosis. So this has a really high fetal loss rate, and you get a disproportionate blood flow to one of the two fetuses. So you get a donor twin, which transfers excess blood to the recipient and has oligohydramnios and is smaller. Okay, so the donor is oliguric and has oligohydramnios around it. Yeah, so less amniotic fluid. The recipient has polyuria and polyhydramnios. So the treatment for this is amnioreduction, selective laser ablation of the placental vascular anastomosis. So laser ablation of this. This is usually needs to be done in like a really specialist hospital. Okay, so management of multiple pregnancies. So you have the ultrasound scan at 12 weeks, which will confirm multiple pregnancies. You will then have monthly ultrasound scans from 20 weeks. This will be fortnightly if the twins are monochorionic, because there's an increased risk of complications in monochorionic twins. You have full blood count at 20 to 24 weeks, and then again at 28 weeks because of the increased risk of anemia. You'll need referral to a tertiary, so like a specialist centre, if there's discordant growth. So if there's more than 25%, this suggests growth restriction. If there's discordant growth between the two twins, if there's evidence of twin-to-twin transfusion syndrome, if there's any fetal anomalies, if you have monochorionic, monoamnionic twins, you also need referral to a tertiary centre. And if you have discordant death, so if one of the fetuses has passed away and the other one's still alive, you'd need referral to a tertiary centre. Multiple pregnancies are treated with low-dose aspirin if indicated from above 12 weeks if they're increased risk of preeclampsia. They'll need additional iron and folate because of risk of anemia. They'll need weekly antenatal visits from 30 weeks. And for uncomplicated dichorionic twins, they'll need an elective birth at 37 weeks, and for uncomplicated monochorionic twins, they'll need elective birth at 36 weeks, because usually more complicated. Usually more risk, sorry. Okay, so we're coming to the end now. So Puerperium is basically 6 weeks after delivery, and it's when the body is returning to its pre-pregnant state. So lots of different changes that take place. So to do with the genital tract, the uterine size reduces over the 6 weeks. Within 10 days, the uterus is no longer palpable. The os closes by 3 days. If you're not lactating, then you get your period after 6 weeks, and you get like a flow of vaginal discharge and bleed for 2 to 6 weeks post-birth as the lining renews. Okay, so to do with the cardiovascular system, your cardiac output and plasma volume decrease to pre-pregnancy state within 1 week. You get loss of edema and blood pressure returns, and the return of blood pressure to normal can take 6 weeks. Your white blood cells decrease. You get platelet and clotting factors increasing in this time. Okay, so postpartum pyrexia. This is a temperature of more than 38 degrees in the first 14 days following delivery. The most common cause is endometritis, which is most commonly caused by retained products in the uterus. Other causes include UTI, wound infections, mastitis, and venous thromboembolisms. So the management. If you suspect endometritis, the patient needs to be referred to hospital for IV antibiotics. And these are continued until the patient is afebrile for greater than 24 hours. So the risk factors of endometritis: prolonged rupture of the membranes, prolonged labour, low socioeconomic status, so if you've given birth, if you've had a home birth in a poor hygiene environment, having multiple vaginal examinations during birth or C-section, and maternal diabetes. Okay, postpartum psychiatric disease. So there's three that you need to know about. So you have baby blues, which usually occurs around the third day after giving birth. It's temporary emotional lability, and it's characterized by like anxiousness, tearfulness, irritability, and kind of the management is just supportive and reassurance required. It affects 50% of women, especially first-time mothers. It usually resolves on its own just with support and reassurance. Postnatal depression, the symptoms are tiredness, guilt and feelings of worthlessness, difficulty bonding with the baby. Also, one of the signs to be aware of, so one of the like clues might be in like a mother who's not breastfeeding for no reason, as in there's no reason that she can give for why she's not breastfeeding. That's something to pick up on, because it might be because she's finding it difficult to bond with the baby, and that might be because of postnatal depression. So the management is social support, psychotherapy, so CBD, antidepressants. The one that's best to use is it's one of the SSRIs, and it begins with P, but I can't remember the name at the moment. But yeah, it's an SSRI that's best to use for postnatal depression, and it affects 10 to 15% of women, and it's during the first postnatal year, and it peaks around 3 months postpartum. And then you've got puerperal psychosis, which is characterized by severe swings in mood. So it's similar to bipolar disorder, and disordered perception. So you get auditory hallucinations. It's a high suicide drive. You get abrupt onset of psychotic symptoms, usually around the fourth day, and it affects 0.1 to 0.2% of women, and they usually require admission to hospital, and it has a 20% risk of recurrence following future pregnancies. Okay, that's the end, and my laptop is about to die, and this was a very long presentation, so thank you for listening. Yep, if you want the presentation, just let the admins know.